Okay, so we proceed with the third speaker on the list, waiting for the first one still, is Charlotte Moser. Is a clinical oncologist from Belgium, the Netherlands, now here in Boston. And she's a clinical oncologist, but also interested in survivorship issues, medical device development, and also drug development. So she will entertain us with, I think, very interesting topic, predictor care, personalized complication risk prediction tool. Please, Charlotte.
Yeah, again, good morning. I had to announce that I'm not Electa anymore since the 1st of May. I am on my own feet as an entrepreneur and consultant. And I want to talk about a research and a project which is different. It doesn't need complicated machines. It doesn't need a research lab. It doesn't need mouse experiments and can be done everywhere in the world. I want to address the pain point while we sit here, not only on the user side. We heard about all the things lacking in Africa, India, Pakistan, etc. I want to turn it around. I want to make it something possible for those oncologists on the ground seeing patients and how we can improve their lives, not the patient lives, indirectly their lives. Because what are they facing? As an oncologist, you see a patient with a problem, which is cancer. And what you do is you dig into literature and your own knowledge to know what drugs or treatments are there, proven to be efficacious. So you go into the guidelines, you go into PubMed, and you find the drug or the combination radiation of surgery, which has been proven, but it has been proven in clinical trials done mainly 90% in the Western world, right? They're not done on your regional population. As well as they're performed 90% in early stage cancer. They're not performed in that advanced suffering patient you have in front of you. So more than 70% of clinical trials are aiming stage 1, 2 disease. Okay? So it's difficult to find knowledge or guidelines of advanced, local regional advanced breast cancer patient. Okay, so you already have little knowledge, written knowledge and guidelines on your back to make a medical decision. So what are you going to offer? Every oncologist, at that moment you make the trade-off, you're not only looking what will be the response rate, but you also have to trade off the costs. The cost, what that drug will mean financially, or do you have that radiation department behind you or not? The availability and the cost of that financially and logistic, but as well as it means for the patient, the risk you're going to take. Because if every treatment has side effects, we cannot forget that. And we make that mental calculation every time you have the family and the patient in front of you. That knowledge of side effects is also based on clinical trials, what we are reading in journals and what we find in PubMed. Toxicity equals between 5 fractions and 30 fractions, or this drug is safe, okay? Those regimens are tested in a populations who are far more fit and younger than you see in general in front of you. We know that patients treated in clinical trials, just by being treated in a clinical trial, lives 30% better than those outside trials, okay? So you are not sure about your knowledge, what you're going to give in terms of efficiency, and you're not sure what you're going to cost. Okay, and I think that is a pain point I want to tackle in the Western world because that trade-off is everywhere equal. However, toxicity in the Western world today gets relative, right? We can be so precise, as we say, or we can be so monitoring well that we can tackle that quite good. When you are outside the Western world, you lose your patient too easily far away, 4 kilometers away, and they are having more advanced disease and they are far more fragile, okay? So I'm still in my first slide, okay? But this is the backup. What is reality today is that we see less cancer still in the non-Western world. But when you look at the mortality, the ratio, how deadly the disease is shocking. Every time I show this is man, and we talk about gender relation, women are as bad, right? That mortality is not only cancer mortality. It's also mortality because of treatment. And we should not forget that, okay? So when you're going to prescribe chemotherapy, there is a risk, or a reality, that you will kill the immune system of that patient. And that means that HIV or a stupid common cold can take over and become mortal in that patient, okay? What we do in clinical practice is we see a patient, we try to make it as compliant as possible, so to really motivate, to say, okay, I'm going to do something with you, but you have to help me. You have to comply, you have to come back. And every time you feel not sure, ring me, okay? So you work on your emotional, but binding all capacities to create compliance. Okay? You're going to educate, and you try to find tools to monitor what you're doing. The moment you prescribe, what are your trade-offs? You want to know how they have been treated before, how fragile they are, how old they are, what kind of disease they have, and what are other diseases are in there as well. Okay? So there are in every country the same risk factors. We know if you do a 5-FU treatment in the Netherlands, Amsterdam, or in Cape Town, it's the same. It's the same drug, and you think you make that mental counting the same way. However, the background is not the same. Maybe tumor pathology is not the same. Genetics of the patients you are treating are not the same. We know that there are certain genetic profiles who are far more sensitive to toxicity than others. They cannot eliminate the 5-FU, 10% of the patients, or they really react badly on radiation. That's about 1%. Okay? For today, we do a 5-phases questionnaire. We look at the blood counts, we go and we cross our fingers, right? That's reality. Today, with our communications and data collection tool, I think we can do far better. So and there I come to my project, where I would like to have your interest, because what I want to do is to collect data of your populations and to see what is prescribed, okay, and what happens after. Because if you come in the title, if you want to predict outcome in terms of toxicity risk as well as efficiency chance, you have to have large groups and come to a conclusion. And I'm talking now not about randomized trial settings, I'm talking about real population data, which is our region dependent, okay? This is a whole industry which is already going on because we have far better data collection materials, cloud, whatever, going there now, possible to do this. Okay? But what happens is, it happens in the Western world. So whenever I come with a tool, will not be applicable for where you are. Okay? The algorithm is not the biggest problem. How to predict, if you have the data, the algorithm I have already. I have the team to do that. Okay? What I need is the data collection and test that. The test, what is tested in the Western world, to test also in India or in Cape Town or other regions. Okay? How does it work in practice for a physician? And now we really need to catch up with Chapsnot, whatever, Facebook. I'm even the wrong generation here. But we have to catch up there because those patients and physicians, what they have their mobile phone. Okay, they're going to use that. They're going to use that to do the education, the monitoring, and the questionnaires, and to make them also communicate among each other. Because that we spoke about the mental and all the cultural difficulties around cancer in your regions. and that comes aside. We have to work on that compliance part, because data and just giving will not result. We need to know what happens after. Okay? It's not expensive to develop that app. Okay? I'm looking for the physicians who want to use it. Okay? Of course, I'm looking for investment too, because there is an initial investment involved, and I would like to partner with local education and compliance improvement projects who are already on the ground. So that's what I wanted to ask help for, not in my own title, but for all the regions where you come from. Thank you.
Thank you, Charlotte. It's very, very interesting. I'm sure there will be questions, especially from the companies, maybe, whether there is some interest in investing. Yes? Well, wait.
My name is Jipendra Marathi, Seven Hills in Houston. So what type of data are you collecting? Why is it important to collect field data versus, say, going to the VA system where there's a lot of information on all the various environmental and treatment issues, and that can be tracked on a retrospective basis?
Because they are not well supplying the toxicity data. So you get the treatment data, you get the demographics of the patient, the gender, or the well-known 5 risk factors, you can, but you don't have the follow-up. An outcome is not disease progression, which you can find, or death by disease, and confounded with death by toxicity. You have to have the toxicity details, and that you need to get from the patients themselves. Yeah. So simply that data is not out there. And it's not only a scientific tool, it needs to become a communication tool as well, which has his own life, right? You need also to start working with it, getting experience with it, so you can build this from this predictive model to other predictive models.
One more question there, please. Wait for the mic, please.
Follow-up to comment on your question. I believe what you're also looking for is the toxicity or side effect of patients of different origin, different race.
Yes.
Because what side effect you get in the Western world of a breast cancer patient or a colon cancer patient is different in the Asian population versus maybe in African population.
Yeah, in Africa, you see relatively younger patients because they have the means or the condition to come to the clinic rather than the even more fragile older ones. The biggest problem is the stage. So they really come with advanced stage. We have not enough knowledge. We can be proud of our Western world with screening to have made that improvement, but that improvement is not reality in Africa or India yet. So that advanced stage reaction to treatment and complications is quite a blank page we have to fill with science, yeah.
More questions or comments?
But please come to me this afternoon or tonight, yeah.
One more, please.
Oh, yeah, please.
I'm a practicing oncologist in this country, but in West Virginia where we're a little bit more challenged. And I'm glad you're talking about real-world data and real-world evidence, because what the information that we have from clinical trials, less than 10%, perhaps even 5%, even in this country, are treated from that, and we try to extrapolate that into our own practices, and sometimes it just doesn't work. So the real-world data is, so we have to, I'm glad you're collecting that data. And I suspect that a lot of that data will be collected from the conversation that you have between patient and patient, if you're able to get that social data as to what really is happening to them.
Yeah, and that's linking back to the former question. So we tried to make the algorithm run in insurance data. And they are far complete on the treatment side, on the demographics, but they are not complete on the toxicity side. So they're getting more complete on compliance because the insurers are also aware or keen on making patients finish or having a good result. But all that is work in process, right? And 90% of, or 99% of research is focused on efficiency and cure other aims.
One more question there, please.
I need some clarification. Are you looking at acute toxicity or chronic toxicity in this project, or both?
No, in this to the acute neutropenia, febrile neutropenia is the first one, is the most mortal one.
Yeah.
And I think our first algorithm is about predicting that, because that's the mortality risk. I'm not talking about this skin toxicity or bowel toxicity, but there are other algorithms, especially on immunotherapy-related diarrhea and GI effects. You can run the same algorithm.
Okay.
But for me, this is focused on neutropenia because you're talking about mortality. Okay.
Okay, thank you. Any more questions, comments? If not, thank you, Dr. Moser. We